We are here today for the pre-GA session on obstetric violence by Dr. Tanaya. Dr. Tanaya is an internationally trained medical doctor, embryologist, and scientist who is passionate about medical education. After studying for a master's in the University of Oxford, she subsequently registered as a doctor in England and committed to making public medical education her life goal. She was awarded Influencer of the Year 2020 by SH24, the online sexual health partner of NHS UK. Currently, she works as a doctor at Abhilasha Hospital and Fertility Center in Allahabad, India. She has been elected a Fellow of the Royal Society for Public Health, is in the founding committee of a medical technology startup, regularly conducts um, sexual and reproductive health awareness campaigns, and runs her own Instagram and YouTube channel at Dr. Cutress, dedicated to public medical education. Welcome, Dr. Tanaya. I'll let you take the floor now.
Thank you so much for that wonderful introduction and telling me all about your organization and all the brilliant work you're doing. Today, I'm here to talk about a slightly more heavy topic and a slightly more, let's just say it's not something that we happily discuss so much. There is a lot of stigma around it, particularly in the medical fields. We don't like to address it. We like to pretend it doesn't happen. But I think it's very important that we do discuss it, especially on a global forum, because of the far-reaching consequences of it. Actually, can we have the next slide, please? So I want to get a little bit of an idea of what everybody here thinks what obstetric violence is. If you have any ideas, please drop them in the chat box so we can learn from what you expect obstetric violence is and then share what the textbook definition of it is and compare our ideas and perceptions of it. Maybe just a few words, just anything. What have you heard this is? Have you heard of this? So there's the use of non-evidence-based obstetric procedures, absolutely. Anyone else with any idea on what the term obstetric violence might mean? Not respecting patient autonomy, yes, that's a very important point. Undignified and abusive treatment in a hospital setting towards the birthing patient. Wonderful, and great language there as well. Performing procedures without patient consent, not listening to the patient's need and desire, dismissing the preferences of birthing persons. That's, yeah, I think people do have a good understanding of what this means because you guys are sort of describing everything that I've written in my PowerPoint. So basically, yeah, that is basically what it is. Juma, could we have the next slide, please? So by definition, according to the International Journal of Gynecology and Obstetrics, it's basically a triad that involves pathologizing birth. So birth is a natural phenomena. Birth is something that we have been doing for millennia without medical intervention. And that's not to say that medical intervention is not required in certain cases. It is very much required. But for most births, we require supportive care and not interventional care. So pathologizing birth, dehumanizing the patient in terms of violence, in terms of abuse, in terms of taking away, not listening to their consent, not listening to their preferences, not having a birthing plan, and lack of autonomy, which means that the birthing person, the patient, does not have any autonomy. Look at my language, I'm calling the person patient instead of calling them a birthing individual. So there's a lack of autonomy in what they want to do, what sort of birthing plan they want, what procedures they want to have, what procedures they don't want to have, what exactly they would like. So this is the triad definition of what obstetric violence might mean. Now, this is also a legal term in certain countries, particularly Argentina and Venezuela, because from what I understand, there is a little bit more of a focus on obstetric autonomy and, removing obstetric violence in these countries. And I wish the rest of the world would follow through. So let's move on to the next slide, please. So what do you believe encompasses obstetric violence? I believe I've already gotten some brilliant answers from you guys, which does describe the things that I will be talking about, such as dismissing the preferences of the birthing person, not listening to patient need and desire. This is massive. There's no autonomy, there's no respect for what they want. It's a very patronizing environment where we tell them what's better for them without understanding their needs, their requirements, their situation. Undignified and abusive treatment happens so often. So let's talk a little bit about the kinds of obstetric violence we can see. Next slide, please. So one thing that we very commonly see in India, I don't know how routine this is across the rest of the world, is that we see it's always called vaginal. Instead of a vaginal delivery, we call it a normal delivery. Even in a medical setting, if you go to the hospital and your obstetric history is being taken, the doctor will ask you, did you have a normal delivery or did you have a cesarean delivery? Now, of course, there's different kinds of deliveries. We have vaginal deliveries, we have interventional deliveries with instruments. So even a forceps delivery with instruments is it's an interventional delivery. And then, of course, we have cesarean sections. But calling it a normal delivery is sort of implying that all other deliveries are abnormal. What does that mean? And that sort of language can be very demotivating towards the patients. A lot of people, even in an emergency situation, feel very reluctant for getting a cesarean section because that means they didn't have a normal delivery. There's a lack of respect for the gender identity, for the caste, for the ethnicity, and all other variants. So we don't respect the patient's background. We don't, again, see, there's a very good example of this is me. I keep calling them patient instead of calling them a birthing person. And so there is a lack of respect for their background and their diversity. A lot of times we use medical language without giving any explanation. So we'll say, there's polyhydramnios, so we need to do an emergency cesarean section because there's fetal distress. Instead of actually getting down to a level that they might understand, the terms they might know. So we have a language-based barrier of obstetric violence, level of obstetric violence. There's also autonomy. For a lot of cases, particularly in overworked centers, we have induction of labor without the need for it. Sometimes we don't need to induce labor, but it's still routinely given. I think everybody would know that. Anybody who has had their labor room posting or their OBG posting would have seen that. There is unnecessary acceleration of a natural process. We have been birthing for millennia without needing acceleration. And that's not to say that long labor should be promoted, but if it's happening without any issues, if there's no maternal exhaustion, why is this happening? Did we take the patient's consent for acceleration? No. Then there's a lot of times cesarean sections happen without any indication for it. Similarly, in a physical condition, there's a forced supine position to give birth. Now, a lot of people would prefer to give birth in a vertical position, but there will be a forced supine position. Their legs will be up in stirrups, and a lot of times these stirrups are not even comfortable padded stirrups. They can just be little loops of cloths that you have to stick your legs in and just stay like that for say 4 hours, 5 hours. I don't think that's comfortable to anybody, particularly when you're going through incredible labor pains. Early attachment, so immediately after the delivery, attachment of the newborn to the birther is considered very, very good for the birther's lactation, for attachment between the parent and the child. These things we don't prioritize so many times. They're impeded. A lot of times they'll take away the baby for cleaning them up, for taking away the vernix, all of the coating. These physical variants are there, and of course there's always the top of the lot, which is abuse. Punching, pinching, slapping, verbal abuse. This really does happen. This happens more frequently than we would like to admit, and I will get into a little bit more statistics, but let's move on to the next slide for now. So of course this is very tragic and inhumane. If you could go to the next slide. According to a WHO report where 2,600 birthers were interviewed, more than a third of them experienced physical violence, which included being physically, forcibly held down, punching, slapping, pinching. Now, we all know that labor is a fairly demanding, painful, not very pleasant procedure. Imagine being possibly held down and physically abused in that phase. 75% of surgical cuts on the vagina are given without consent. So if an episiotomy is going to happen, and a lot of times episiotomies are required, they will be done without consent. 75% and over. 59% vaginal exams happened without consent. Now, I don't think anybody would like having anybody's fingers in their business without consent in a normal situation. Imagine having that done when you are just writhing around in pain. So we need to empathize more with our patients. 57% were not offered any analgesia. So no sort of pain relief, no sort of supportive care in terms of pain was offered. And 13% reported that they had a cesarean section without their consent. Now, this is not about emergency cesarean sections in cases of fetal distress. This is about non-indicated cesarean sections. Next slide, please. So have you ever noticed any of these in your workplace or educational settings? I would love it if you guys would comment a little bit on this and tell me if you've seen any instance of this happening, not exactly in the definitions I have provided, but in any other way, if you've seen that. It would be really insightful to see a global perspective on it. In case you are going to be offering something that you have seen, it would be very helpful if you can attach the country of your residence or the country of your education next to it. So for example, in India, what I saw was that there used to be a lot of pinching and slapping. There used to be a lot of verbal abuse towards the patients that, of course, poop happens and pee happens in the middle of all of this. Defecation and urination are completely normal physiological processes, especially when there's such high intra-abdominal pressure from the labor pains. And they used to be shamed quite often in the area that I worked in, where I saw it. So if you have, oops, what did I do? The screen has disappeared for some reason. Oh, no, there it is, sorry. So if you have experienced or observed anything of this sort, could you please comment along with where you've seen this, the country of your education, or the country of observing this? It would be great so we can get a more worldwide perspective on how this happens. And in my experience, I asked this question in a global setting with my master's course. And what I found was that, I don't mean to generalize, and this is not a blanket statement, but what I saw was that the threshold of violence was significantly more, for what we qualify as violence, was significantly more in the people who were coming from developing countries. People who are coming from developed countries automatically expected better standards of care. And we automatically expected that, we as in me from India and my other friends from South Asia, we automatically expected that being pushed around and not having your consent respected would be normal things, would be things that everybody does experience. So yeah, if you could share some of those experiences or whatever you've noticed, that would be great. So Peru is verbal abuse, Chrysler maneuver, and episiotomy without consent. Now, the Chrysler maneuver is not very evidence-based. It's not practiced in Europe. It's not practiced in America, in the US. And episiotomy without consent, I think, it's common practice in India. Verbal abuse as well. So this is very unfortunate, and this is very non-evidence based. In Lebanon, verbal abuse towards the patient, episiotomy done without consent. I feel like we will see this as a common theme throughout all of this, which will be episiotomy without consent. Now, the thing with episiotomy procedure is that in the Chrysler maneuver, you basically put fundal pressure almost on the patient while they're delivering. It's quite painful. The patient is awake when this is happening. So with episiotomies, what we do need to recognize is that most of the evidence that comes for episiotomies is generally based in countries with higher socioeconomic status. So they have better nutritional status, which means that they have better developed pelvises, wider pelvises, and a lot of times in developing nations, a lot of birthers that we get are naturally constitutionally so small that their pelvises can't accommodate regular labor without an episiotomy. I'm not saying this is the case in every patient, but it does happen quite often. So yeah, we're getting the episiotomy without consent in India again. vaginal exams and episiotomy without consent, particularly with non-English speaking patients in the US. So yes, this is quite interesting because we see that there is a huge difference in the way marginalized or non-Caucasian communities are treated in healthcare. In fact, there are specific obstetrics programs where you focus on working with communities that don't have enough representation or don't speak English, where you specifically focus on these kinds of patients because historically they've had a lower standard of care than we get in other places. So yeah, if you guys would want to add more, please feel free to add more. We'll move on to the next slide for now. So globally, particularly in Asia and Africa, we see this very, very often. According to this WHO report, more than 2/3 of private sector births in Brazil were by cesarean section. More than 2/3 is a massive number. Now, I'm not saying there's anything wrong with the cesarean section. A lot of people want to go for an elective cesarean section, they can go for it. But in a non-medically indicated or a non-elective scenario, do we really need that number? Who knows? Routine episiotomies, again, we just spoke about this. So you do have to bear in mind that there are statistical differences between populations, particularly in terms of nutrition and their and how much their pelvis can accommodate. So certain populations might need this more, and I wish there were more studies on how the rate of episiotomy were different between chronically malnutrition nationalities versus, well-to-do countries who have better nutritional statuses and therefore better growth and therefore better bone structures, etc. Let's move on to the next slide. So we do understand that nobody goes into medicine thinking that they will abuse their patients. This is not something you step into medical school doing. I know a lot of you are younger doctors over here. So I don't think any of us went into medicine with the idea that, oh my God, let's go and pinch some patients. Nobody does that, right? We all go in with the idea of helping people, and we all go in with the idea of relieving some kind of pain or some kind of stress that comes because diseases exist, because pain exists, because conditions exist. So something definitely goes wrong along. Feel free to move to the next slide. Something definitely goes wrong along the way. And we have things like a lot of our staff is it's completely understaffed. Because they're understaffed, they're overworked. Now, along with this comes another problem, which is that we have an acute scarcity of supplies. One thing that my mother always mentions that she learned in her internship, which is the years after finishing 4.5 years of medical school, we do 1 year of internship in India. And she said the first thing I learned in my internship was how to get the rich patients to buy more things so we could save it and then offer it to the poorer patients. For example, if you have to send somebody to buy 3 syringes, they need 3 syringes for this day, you will ask them to buy 6, and then you will save 3 in your pocket because you will definitely get 3 patients that day who will need a syringe and will not be able to afford it. So there is a massive scarcity of supplies. There's so much poverty. And on top of all of this, we have a very dehumanizing training system all across the world. This is not a developing country specific problem. Anywhere in academia, be it a PhD setting or be it a residency setting, junior doctors and doctors in training are not treated well. Be it from our seniors, which is people who are in the years above us, or be it from our teachers or our supervisors or the administrative staff. There is a very rampant abuse of doctor resources. They're not just doctors, any healthcare providers. They're not paid enough. They're not given enough support. And if you could just add, so Vedant is mentioning that this is a very common practice in government hospitals in India. We did the same for syringes, gloves, and even drugs like heparin at times. I actually did the same in my internship at a very large district pediatric hospital during my internship. So on top of these issues of scarcity of supply, overworked and understaffed, and dehumanizing training, we also have this on top. We have a lack of support and potential PTSD in healthcare providers because we get to see a lot of very critical scenarios. We lose patients. Sometimes we don't lose patients, but we carry the work home with us. There is a potential for PTSD. There's a potential for just being completely overwhelmed by the work situation we are in. Particularly right now in COVID, where in India, there's a lot of situations where people are having to triage on the basis of who is going to survive longer, that person should get the bed. So if it's a choice between a 70-year-old struggling for breath or I don't know, a 30-year-old struggling for breath, the doctor is left to decide, I have one bed, I might as well give it to the 30-year-old one because the 70-year-old one might not live as long. So, there are these situations, there's so much potential for PTSD. On top of that, we don't have supportive work environments in most countries. We don't have a lot of trained paramedical support. Particularly in obstetrics, we don't have a lot of midwives, we don't have a lot of doulas. So expecting a fully trained doctor to manage 10 patients and be there for all of their vaginal deliveries is an impossible task. And in this case, we need midwifery support, we need doula support, we need paramedical support, which we don't have most often. We have a lot of abusive work environments. I think everybody here would agree that we don't work in sectors where our mental health or our physical health, even for that matter, is prioritized. All of us, all across the world, as doctors, are heavily overworked to death. And there is no training in healthcare human rights. So we're not at all trained in what it means to provide human rights to our patients and what it means to provide inclusive, holistic care to our patients. A lot of times, because of the patient load, particularly in developing countries, our approach is, okay, fix this problem, give them this, fix this via surgery, and let's move on. We don't have the time to think about how we can dramatically alter their lives and how we can prevent these things from recurring, because there's just so much patient load, which of course in turn leads to a rampant abuse of human rights, which in turn is very sadly borne by the patient. So all of these things, which should, we should be provided a better platform, we should be provided better support in all sort of ways, but the patient has to bear the effect of this. Next slide, please. So this is essentially what I think most residents are like, the entire world is on fire and they're like, this is fine, I'm all right. Next slide, please. So what factors do you think contribute to this situation? If you have any ideas, aside from what we've already discussed, why we can't entirely put the blame on obstetricians and healthcare providers. I understand a large part of the blame does eventually have to be borne by us, but there is a situation, there's a systemic failure, there's a policy level failure because of which these things are happening. So what other factors do you guys think contribute to this? Next slide, please. Please keep mentioning them in the comments if you have any ideas on this. Oops, okay. So another couple of things that do happen is that there's an impaired doctor-patient relationship. This, I'm speaking from a very India-specific context, which is that doctors are tried in consumer protection courts, which means that the patient is a consumer or a customer instead of being tried in a medical negligence case. For example, if there's a birth complication we can't prevent, say there's obstructed labor, say there is birth asphyxia related to it, that's not something we can necessarily prevent. Yes, we can take all sorts of precautions, we can do everything possible, but still accidents happen. Still, these kind of situations happen. And then the doctor is dragged to consumer protection court. So a lot of care becomes, how do I prevent litigation? A lot of care. So I'm a registered doctor in the UK, and while this is not the way we were taught, but while I was doing my second exam, which is the clinical exam, a lot of focus on the answers were make sure that you don't answer in a way that the patient takes you to court for it. So there's a very difficult situation in the doctor-patient relationship. There's an absolute lack of trust. Next slide, please. So, which is where I sort of come to the question that have we gone from patient-centric care to convenience-centric care in terms of increased rates of cesarean sections where they're not indicated or accelerating labor, or even to litigation prevention-centric care. This is unfortunately the side effect of the sort of systems we are in, that our priority becomes how to prevent litigation and how to basically cover your tracks, and not cover your tracks, I think that's a misleading way of saying it, but how to basically make sure you've got all of your bases covered, so you don't get taken to court for something you couldn't have prevented. Next slide, please. So why it's very important that we do talk. I do understand that a lot of these situations that are happening and a lot of these reasons why this is happening is because of things we can't control. There are policy level failures. Like Lotta commented that a lot of OBG is not prioritized a lot in policy. Surgery and orthopedics have an anesthetist dedicated to their service, but OBGYN doesn't, because so many birthing persons can't get ready for even C-sections in time in Sweden. So I think this is across the board, this happens everywhere. So what happens as a result of this is that it drives a lot of birthers away from formal healthcare, which in turn leads them to going to untrained and unscientific individuals for their obstetric care, which in turn leads to increased mortality and increased morbidity, which in turn eventually leads them to coming to Western medicine trained doctors, which in turn leads to an increased global healthcare burden, which are very preventable issues at the basic level. If we prevent this rampant abuse, the WHO describes obstetric violence as a violation of human rights and as a violation of women's rights, because that's exactly what it is at its crux. It leads to so much of a reduction in access to healthcare. So many people just don't go to the doctor because they're afraid that the doctor will berate me. This happens very rampantly in India. So I'm speaking from a very India-specific context over here, that there's a lot of fear that the doctor will berate me. I worked briefly at the Gender Identity Clinic in London. I shadowed them. And a lot of times, a lot of trans individuals would just not go to the doctor because their healthcare would not be prioritized, or they would be discriminated against, or if they wanted to pause their transition in the middle to have a child, they would be ridiculed, they would be shamed. So with this holier than thou paternalistic attitude that a lot of doctors tend to espouse, we reduce access to healthcare and we directly increase the global burden of morbidity and mortality. And that's a massive problem. Next slide, please. So what can we do about it? We can crib about it all we want. We can talk about it all we want. Essentially, how do we change this? Next slide, please. There's something in the NHS that we learn which are called the FRIDA principles. So this is a common mnemonic you can easily learn. Every time you're offering patient care, you have to remember these 5 principles. Is this fair? Am I taking into account all kinds of fairness for this person? Am I being respectful in my demeanor and my treatment? Is this equal treatment? Would I offer the same treatment to somebody else? Would I offer the same manner of treatment to somebody else who were from a different caste, community, background, gender identity, sexual orientation, whatever? Is this dignified treatment or not? And lastly, am I respecting their autonomy or not? So these 5 principles are the fundamental ground for providing patient-centric care. And as long as you respect that, you can provide, you can provide healthcare that is several-fold better than what you would provide in violation of these. Because if what you're doing doesn't fit your patient's lifestyle, if it doesn't fit their demands, if it doesn't fit their requirements, are you really helping them, or are you exacerbating the problem for them? Next slide, please. At the policy level, this is actually my advice for any of you who does want to become an OBG in the future. Residency is not a hazing ritual. It is not a ragging time. It's not just because I went through torture in my residency, I will torture the next person. Please stop doing that. This is contributing to an ever increasing vicious cycle of burnt out obstetricians. So we need to mitigate burnout by providing more mental health support. We need to have more supportive work environments, and we need to have supportive healthcare. We need to have paramedical people, we need to have doulas, we need to have midwives, we need to have counselors, we need to have lactation counselors, we need to have a birthing plan. At the policy level, there's so many things that need to be implemented. And the biggest thing that needs to be done is we need to stop prioritizing incentive-driven care. A lot of corporate hospitals in India have this idea of, we have to do at least 20 cesarean sections this month. Then there is an incentive attached to it for all the healthcare providers, which basically means that the best possible care we could provide to the patient-centered care, goes immediately out the window. Next slide, please. And that's all. That's literally all I wanted to talk about. Why it happens, how it happens, and what can we possibly do for it. I hope this was helpful in some way. What I really wanted to do at this stage was to sensitize you to the fact that this happens, and to sensitize you to the fact that you might perpetuate this at a certain point in your career. You might be a part of this at a certain point in your career. So make sure you check yourself, make sure you follow the freedom principles, and make sure you try to empathize with your patients. And if you're in the policy-making sector, please try improving access to healthcare for people. And when that healthcare is provided, try making that healthcare patient-centric and not incentive-centric. Thank you.
Wow, that was amazing. So many things to keep in mind and so many things to reflect. I think now is the time where we open the floor for questions. If you have any questions for Dr. Tanaya. I noticed a few people raise their hands. If you want to speak up now, you can and ask questions, or you can write it in the chat box. Yeah, Natalie, please go ahead.
Yeah, no, thank you so much for this awesome session. And I think that, as you mentioned in the beginning, obstetric violence is so left out of the conversation in medical school and in postgraduate training. So I think it's very important for us to talk about this. You mentioned in the beginning the over-medicalization of the birthing process. And so I am curious how you speak to birthing persons about practices that are kind of left out, such as midwives and doulas, and just what your opinion is on the inclusion of these individuals in the birthing process.
I think they can provide a very important supportive role. I don't believe that we should transfer all antenatal care patients to doulas and midwives. I believe that they offer a supportive role in terms of the fact that pregnancy is a life-altering experience for most people, and they don't have the space to ask a lot of questions or have those questions answered because of the patient load that's there on doctors in general. And not just patient load, administrative load, surgical load, there's so many things. So in that case, there's so many things that trained supportive care professionals can provide and have the space to accommodate than doctors can, which is where, for example, if an antenatal patient comes to me, I would like to assign them a small team of a midwife who can explain to them what are the things that are going to change in their body, and then maybe a lactation consultant eventually, who can explain to them how latching works, if they're having problems with latching, how not to feel frustrated. Another thing that happens quite often is people develop lactation aversion, where they just get frustrated from, feeding the child all the time and, all of these things. Then maybe a physiotherapist who can consult them a little bit on their exercise, and a nutritionist who can consult them a little bit on their nutrition. Now, they can access this if they want, and they can leave it if they want. We need to stop making pregnancy, what my mom always says to her patients, which I find very, very useful in my practice as well, is we actively tell our patient pregnancy is not a disease. It's a normal part of life that we can tweak a little bit to accommodate it better, essentially.
Thank you for that answer. Is there anyone else who wants to ask a question? If not, I have a question of my own. You said that autonomy is also quite important. And in settings like in developing countries where we have a lot of rural population coming in for deliveries, majority of the time they do not have a very clear idea as to what they, because they're quite scared, they're quite unsure about what is happening in the moment. How to ensure that they get proper um, care and everything which is communicated very easily to them, because what they prefer, what I've seen is they say whatever you feel like you can do it, right? So you might be knowing that feeling. So how do you bridge that gap between a patient who thinks that whatever you're doing is all right, but we also want their autonomy to the best of our abilities?
That's a brilliant question, and that's something I thought about often when I was in medical school, because I used to see a lot of house and I was like, oh, patient autonomy. Then I went into the clinics and I was like, yeah, what about patient autonomy here? So in this case, the first thing that I understand that this is more of a long-term change and it's not something you can implement right now, particularly in developing countries. We need to focus a little bit more on patient education. And this would involve learning non-medicalized language in our medical schools. So as long as we understand that, then we can explain to our patients in simpler terms that these are the two situations you have, and then give them the option of choosing. If they in the end eventually say you do what you think is right, then you're still exercising or respecting their autonomy. Instead of telling them that, this is your situation, so I'll tell you this is what should be done, instead of giving them any background information on what might be happening. Again, this is a longer term and a more complicated answer, especially for our situations where we don't have this sort of space a lot of times. But in an ideal world, this is what would be the answer for me.
Yeah, thanks for that answer. We're also still open for questions if anyone wants to ask any. Yes, Lotta, feel free to unmute your mic.
Thank you. Yeah, I wanted to ask, what's your impression? Is this on the rise, or is this kind of an old phenomenon that's slowly kind of fading away? Or what do you think? Like, what's the trend, or like what's the pattern in the incidence of obstetric violence, and also the global distribution? Is it shifting, or is it really like global?
I think we're getting more empowerment in terms of patient conversations, particularly with social media. We unfortunately have a lot of sensationalist posts where, there will be a very sensationalized account of what has happened. But because of that, this whole image that we've had for so long of doctors being put on a pedestal is changing. And I think that's great, because that allows for accountability. So in my personal opinion, I may be wrong. I don't know the statistics on it, because we haven't covered this a lot in the past. It's only a recent, the first conference on obstetric violence was held in 2010. So it's literally 10 years old, this concept in an academic setting. I do believe it's changing, but I may be wrong. There's another question in the chat box that I did want to take up, sorry. Which is that, as you mentioned, that training can be quite dehumanizing at that time. How do we tackle a situation of obstetric violence from a senior OB-GYN, which I don't know how to answer, to be very honest, because I know how toxic departments in training hospitals can be. There's a lot of pressure from the senior doctors on how you should behave. They get very personal. The priority is not on patients. There's a lot of gossip. There's a lot of competition, very unhealthy competition. And I don't know how to tackle this. I'm sorry. I genuinely have no answer to this. There's another question, which is in a high volume, in a high patient flow setting where we observe violence quite often, how do you suggest we take the issue with more senior doctors as medical students and interns? Bringing up conversations like this, I feel like definitely encourages the space for it. And what I will tell you for a fact is that you will face a lot of resistance and you will face a lot of flack from your seniors as well. because they'll come and tell you that you don't know what we go through and you don't know how much we have to tackle and what we went through in our days. This is a conversation I faced myself when speaking to other people, particularly other gynecologists about obstetric violence. So initiating non-confrontational conversations on this, where you can have maybe a journal club on this, maybe like a CME on this, would be good ways of initiating conversation on this, essentially.
Lotta, do you still have a question? Your hand is raised. Okay. Natalie, you can go ahead.
So I'm curious if you have either seen firsthand or have any ideas on how we as either current medical providers or future medical providers can work to try to promote more obstetric focused policies. I'm just thinking about like the lack of dedicated anesthesia and how it's so left out, and what we can do to drive that change.
A lot of people that go into medicine actually go into administration, particularly in developed countries. That happens. That's very, very common. After medical school, you'll go into MPH, and you'll go into policy, and you'll go into global organizations. So if you are somebody who's making that choice, push for these conversations. I think that's probably the most reductive answer I can give. But yeah, we need, essentially, for the longest time, OBG has been considered, I'm giving you an India perspective on this again, but a lot of times it's considered that the doctors in OBG are very frustrated, and they're overworked and they're overtaxed, and there is a very rampant abuse of work-life balance, particularly in OBG. So a lot of people tend to run away from it because of the general perception around it. So choosing OBG because you like the profession, and then moving on to a policy level, which happens quite often, particularly with public health and these things, is a great way to push more conversations and push more policy level changes on this.
All right. I think there are no more questions, and I thank you a lot. It was a very nice session, and there were so many thoughts rushing through my mind when you were describing instances and times where such difficult situations have occurred, and we'd had to sit back and see those difficult situations. But I'm sure now that we've talked about it and know more about it, we'll try to implement as many points of FRIDA as possible in our practices. Thank you so much again for being with us, and thank you all the participants for being here.
Thank you so much for having me and for being a patient audience for a very dark topic.
All right.